injured cardiomyocytes. So just to begin, congestive heart failure is when the heart can't sufficiently pump blood throughout the body, so organs aren't receiving their fair share of blood, nutrients, oxygen, and it disrupts bodily function. About 600,000 Canadians are currently living with this condition, and the 5-year survival rate is only approximately 50%, which is very, I guess, grim outlook. Some of the causes include myocardial infarction, hypertension, coronary artery disease. The list goes on and on, but myocardial infarction, so a heart attack, is still the primary cause of congestive heart failure. And in terms of treatments, medications do exist. So there's the ACE inhibitors, angiotensin receptor blockers, beta blockers, several others. But the main treatment, the one with the best outcomes, is still transplantation. Whether there's a shortage of organs being donated and still a very high demand for hearts to be transplanted. So surgery is still, transplantation surgery is still the best option, but it's often people do pass away while on the wait list. So other treatments still need to be explored. So one of the ways we can prevent congestive heart failure is by finding ways to treat patients immediately after a heart attack. So I'm going to focus mainly on myocardial infarction. So in this condition is when blood flow to the heart is being blocked. So that's when there's typically a plaque buildup in the coronary artery, and that causes hypoxia to the cardiac tissue. And after, essentially, there's a reperfusion that occurs once that coronary artery is unblocked. And interestingly enough, the reperfusion also causes damage and oxidative stress to the cardiac tissue in the short term. It isn't necessarily, the reperfusion itself doesn't solve or help cure the myocardial infarction or the consequences of the MI. And additionally, cardiomyocytes are terminally differentiated. So any damage that occurs to the cardiac tissue is quite permanent. There isn't a high volume of stem cell or cell turnover in the heart. So once cardiac tissue is dead, that is something that patients typically has to live with for the rest of their lives. Additionally, the tissue surrounding the infarct zone also undergoes maladaptive remodeling, which leads to heart failure. So there'll be hypertrophied cells and additional force being exerted by the cells that are still surviving. And then basically maladaptive remodeling occurs when the cells are no longer able to keep up with that accelerated pace. So other than the therapies that I mentioned previously, stem cell therapies have been really hot in this field for perhaps a decade or two at this point. So this is basically when researchers take stem cells or cardiac progenitor cells and inject them into the heart, either by direct injections or as a patch or hydrogel. Hydrogels are probably, I believe, the most popular at this point in the literature, or more currently at least. Some of the limitations include low rates of cell engraftment and potential risk of tumorigenesis. Additionally, when trying to translate the preclinical results to a clinical trial, there's often very poor translation and just pretty low, I guess, additional repair generation or positive effects on the heart after these types of therapies. However, I guess a field that I find very promising is cell-free therapies. So many people are focused on mesenchymal stem cells and even their secretome, just the soluble proteins and extracellular vesicles that are secreted by these mesenchymal stem cells. And a lot of the other cell therapies that I mentioned previously, when there are positive effects, sometimes, or in many cases, they're able to trace back these positive effects to paracrine actions. So again, the idea of these soluble proteins that are acting on the cardiac tissue, either the ischemic cardiac tissue or the surrounding tissue. And when you actually think about it, MSCs in a sense are a bit more complicated. Like you can't really get autologous MSCs that easily, but iPSCs are much simpler and non-invasive way to generate stem cells. So that's kind of where my focus has been. So the objectives of my master's has been to establish a protocol for generating iPSC secretome and doing so in a patient-specific manner, evaluating the effectiveness of iPSC secretome in treating cardiomyocytes after IR injury, and trying to understand the mechanisms that lead to cytoprotection after this IR injury. So I expect that there'll be a significant, using iPSC secretome to treat IR injured cardiomyocytes will lead to significant increase in cell survival, in improved calcium handling, and also a decrease in apoptosis and hypertrophy. And I believe that there'll be factors involved that include anti-apoptotic factors, angiogenic factors, mitogenic factors, and whatnot. So this is kind of a flowchart of of the methods that I'll be going in. I'll be going into each block a bit more detail. So we generate iPSCs using electroporation. I'm not going to go into too much detail about it, but feel free to ask me in the Q&A period. And from patient blood, we're able to generate colonies of induced pluripotent stem cells, as you can see in this picture. We're able to do so for several lines. Actually, more recently, there have been more lines that have been generated, but for my experiments, I've been using mainly these 6 lines, 5 of which were generated in our lab. The first one was actually a kind donation from Dr. Durkin lab. As you can see, they stain for these cells that we generated stain for all these pluripotency markers. And they also express these pluripotency markers, the OG3/4, NNOG, and Lin28. So what we do is we've generated these cell lines. We're collecting these secretomes. So basically we're leaving these cells in an unsupplemented media overnight, so that all the factors that are in the media the next morning were what was secreted by the stem cells. And then we're collecting this media and filtering out debris and then using that as our secretome for experiments. The model, entry model we're using is, like I said, the IR model. So the cardiomyocytes are cultured 24 hours in a hypoxic chamber, so close to 0% oxygen. And then after the 24 hours, the cells are going to be reperfused for 5 hours in normoxia conditions. And that's like I said, the reperfusion itself is also causes undesirable outcomes in cardiomyocytes. So like I said, I'm going to be looking at calcium handling, cell survival, and hypertrophy. So these are from a paper that was published previously in our lab, and these are AC16 cells after the same injury model. So these are some of the outcomes you'd expect from this injury. We're going to see if we can reduce those effects using the cell secretome. Okay, so here's the workflow for treating IR injured cardiomyocytes with secretome. Like I said, there's 24 hours of hypoxia, then 5 or 24 hours of reperfusion. The 5 hours reperfusion is one that's more clinically relevant, although I've seen both done in literature. But because of the clinical relevance, I'll show you only my results from the 5-hour reperfusion. And then from there, during those 5 hours, the cells are actually treated with the patient's secretome or with a control, and then functional and molecular assays can be done on these cardiomyocytes. So here are some preliminary results. Essentially, as you can see, the IR injury does significantly decrease cell viability. In both cases, you can see that the secretome does partially repair or recover some of the effects of the cardiomyocytes after injury. So it is promising that secretome does reduce the effects of this IR injury on the cardiomyocytes. Also, what I thought was pretty interesting is half the patients that we generated iPSCs from are just healthy donors, so AG for healthy. And then the other half are actually cardiomyopathy patients, because we received these samples from a larger study that my lab is also doing. And as you can see, both of these groups have a positive effect on the cell viability of cardiomyocytes after IR injury. There's actually no significance between the two groups. And the reason why that's interesting to me is because perhaps you could actually use autologous iPSCs for the treating of patients, and you don't have to use some generic stem cells for this secretome treatment or collection. You can actually create stem cells that are autologous to patients, and even if the patient has cardiomyopathy, in this case, they're all dilated cardiomyopathy patients, their stem cells that are generated are still good for generating this positive effect. And then as you can see, this is all the patients' secretomes on and their effects on injured cardiomyocytes. Not all of them are significant, but they do all increase in cell viability once treating the IR injured cardiomyocytes. From there, we're also doing a proteomic analysis of the secretome for each of these patients to see what type of proteins may be responsible for for the effects that we've seen. As you can see, that there's over 1,000 proteins that I need to explore in more detail and really see which pathways I'm most interested in investigating in the future of my research. But it's really promising that there are so many proteins that are being secreted by the iPSCs. So again, this is the whole workflow of my research. And like I said, the iPSCs that I use for my experiments were part of this bigger study called the Heart and Dish study. And what I think the next step of my research is actually not just using immortalized cardiomyocytes for my injury model, but actually using cardiomyocytes generated from these iPSCs. So using patient-specific iPSC-derived cardiomyocytes for my research. One of the limitations, though, currently is that the phenotype of the cardiomyocytes generated using these protocols to differentiate iPSCs to cardiomyocytes, ultimately the cells end up having a fetal phenotype. And there's steps being taken currently to work on maturing these cardiomyocytes and ensuring that they actually do make a good model for research. So one team currently working on this is actually the Otts lab in Boston. And when I saw some of the work that they were doing, I actually reached out to them, and I'm currently spending 6 months in Boston working on with their team, working on the potential effects that pre-epicardial cells may have on cardiomyocyte maturation. So the pre-epicardial cells are actually also generated from iPSCs. And then culturing these two cell types together actually leads to some pretty interesting findings. So in the paper they recently published, it leads to a better arrangement of the sarcomere and sarcomere length, which is a sign of maturing cardiomyocytes. Additionally, there's a higher concentration of mitochondria in the cardiomyocytes, which again is another sign of maturation. So I'm currently in Boston working with their team and investigating this in more detail a bit further. And hopefully the next step of my research would actually be to see, I think, these iPSC-derived cardiomyocytes that we're generating in our lab, making them, or working on the maturation, which we're currently doing here, and then taking the outcome of this research and these cardiomyocytes and using those as my cardiomyocytes for my injury model. I just want to acknowledge and thank my supervisors, Dr. Chiri and Dr. Rotani, as well as my lab mates. And I'd also like to thank the Ott Lab and Durkin Lab. And if anyone has any questions, feel free to raise your hand or send them in the chat. Thank you.
So we're open for questions. Anybody feel free to open up your mic and ask a question to Jeremy. I had one question actually. So do you feel that the iPSCs are more potent at repair than, let's say, just the MSCs? Stem cells?
More potent in terms of how they in terms of the effects that they have?
Yeah.
I wouldn't necessarily say more potent, but definitely more easily accessible. And because you could generate that, they're very easily generated from patients. It's a more accessible mode of generating stem cell secretome. So one thing I will want to do also in the future is to actually compare it to MSCs. I haven't done the direct comparison. I've seen success with both stem cell sources in the literature, but it would be interesting to compare it beyond just like a meta-analysis, but in some direct experiments as well.
Mm-hmm. Anyone else? Well, thank you, Jeremy. That was quite amazing, and congratulations on being there in Boston. Hope all goes well.
I appreciate that. Thanks.
So our next speaker will be Erica. I don't know if she's perfect. Yeah, hello.
Hi.
So from Dr. Veilleux's lab.
Mm-hmm.
And I don't know if you could load up your, are you presenting video or are you going to go live?
I'll go live.
You're going to go live? Okay. So share with us. So Erica will be presenting, the Marketless motion capture systems in pediatric sports medicine injury, prevention, and rehabilitation. Thank you very much. The floor is yours.
Okay. Hi, so I'm going to talk about Marketless motion capture systems in pediatric sport medicine and focusing on injury prevention and rehabilitation. So this is a scoping review in collaboration with Samuel Amanuzzi, Marianne Gagnon, and Dr. Veilleux. So thank you to all of them for all their help. So let's get started. So sports-related injuries are very prevalent among the youth. And so there's a great need for injury prevention and rehabilitation programs for that population. And to facilitate that, there's a need for good biomechanical pattern analysis. And that's where motion capture systems, or MOCAVs, come into play. So these are basically sensing technologies that track movement and then store that data for processing and analysis. So there's two main categories of motion capture systems. There's the marker-based systems that use reflective markers to produce sequential images. And these are widely used or validated. However, they do have some limitations. The main one being that they are limited to in-laboratory setting use. And also they can be quite expensive. It takes time to place the markers, and there can be marker-skin interactions. And now to compensate for these limitations, the markerless MOCAPs are being increasingly used. So these don't use reflective markers, and there's two main types. So there's the initial measurement units, or IMUs, which use accelerometers, gyroscopes, and sometimes magnetometers to assess linear acceleration, angular rotation, and orientation. And then there's a non-IMU category, which is mostly camera-based systems. So although these markerless motion capture systems have been widely used for human movement analysis, the data regarding their reliability, feasibility of use, and validity is scarce in the pediatric population and in injury prevention and rehabilitation. So that's where this scoping review comes in. So we wanted to know the state of the literature on this topic and to identify the research gaps that need to be filled to better understand the potential of these markerless systems in screening and evaluating the youth in field of sports medicine, rehab, and injury prevention. So to do that, we searched 3 databases, Medline, Scopus, and Sports Discus, and identified 734 articles after removing duplicates. And these were screened independently by 2 authors, with a 3rd author decided not any differences. We used the Prisma checklist and inclusion and exclusion criteria. So basically, we excluded all studies that had participants above the age of 24. We also excluded low acceleration speeds, so walking, gait, spine flexion, among others. So because we really wanted to assess sports and higher accelerations, we did not exclude any study based on study design, and we wanted them to have a description of post-processing methods and to be in English or French. So at the end of this, we had 65 articles to extract data from. So what did we find? So in terms of the applications of these markerless motion captures, there's a wide variety in terms of injury prevention and rehabilitation. So they were used to identify injury risk factors, such as excess knee rotation, accumulation of ground impact with running, accumulation of inertial load. They were also used to assess biomechanics of injury processes. So there was, for instance, one study that looked at an ankle giveaway episode and analyzed the biomechanics of that. And they were also used to evaluate the accumulation of workload and fatigue among athletes and the effect of that on performance and injury risk. And in terms of rehabilitation, they were shown to be used to improve in the improvement post-injury. So during this return to sports, there was one participant in a study that had a hamstring injury, and then they assessed the biomechanics in the beginning of the return to sports and the end, and it showed a net improvement in biomechanics. And it was also used to structure a rehabilitation program. So one study compared 2 types of throws in baseball, and they actually looked at the elbow torque and saw that both throws had actually very similar elbow torque, and that one throw could actually be integrated earlier in rehabilitation programs than previously thought. And it was also used to observe rehabilitation of neuromuscular conditions such as cerebral palsy, as well as in wheelchair users. In terms of pros and cons of these markerless maps, it's really hard to draw any conclusions because of the great variety of different types of markerless MOCAPs that were used and the different assessments that were done. But there is a lot of positive features that were mentioned in many studies, and these included portability, ease of use, cost and time effectiveness, and objectivity. In terms of the cons, they were really more specific to each and every circumstance, but these included sensor drift, skin artifacts, limited battery life, obscured post-processing with high accelerations, for instance, in like boxing punches. And for the camera, it was also some difficult point-to-point correspondence. So in terms of the gaps, the main one is really the lack of standardization in the assessment. So the lack of standardization in terms of IMU placement, so the number and location of IMUs that were used for different movement and sports assessments, as well as the type of IMUs that were used, the movements assessed, and the post-processing methods. So it's really hard to determine really the validity and the reliability of these technologies and to determine which ones are better with this lack of standardization. And there was also a penury of comparative studies that contrasted these items. So for instance, it would be relevant to study different types of locations of and placements of IMUs for a specific movement assessment to determine which one is most accurate for that specific context. Otherwise, there was also a lack of studies evaluating high accelerations and pediatric populations. So our age range was 0 to 24 years old. And really most of the articles featured older teens and young adults. So there's a really lack of studies in the younger population. And there was also a scarcity of non-IMU camera-based systems assessed. So really, most of our articles featured IMUs, and these camera-based systems are promising technologies and they should be studied further. Otherwise, there was also a lack of validation studies. So most comparative studies that we saw compared markerless mocaps to other markerless mocaps or other technologies. And there's really a need for more comparison to gold standard systems, which currently are the marker-based systems, although they do have their own limitations as well. In terms of injury prevention, there's a lack of data on the actual risk of injury associated with a certain biomechanical pattern. So for instance, a certain degree of elbow torque, what is the actual risk related to that like parameter and biomechanical pattern? And further, there was also a prevalence of studies evaluating males compared to females. So there's a gap in terms of male to female ratio of studies. And there's also a need for a comparison of female and male biomechanics and its relation to injury risk, given that we do know that there's different biomechanics in males and females and different risks, for instance, in the ACL injuries. So in conclusion, this is a promising technology in the field of sports medicine that can be used outside the laboratory setting, so in the field, but we cannot extrapolate and generalize and say that this can be used in all circumstances. So we have seen it used in swimming assessments, running, jumps, ski landings, among others, but we cannot generalize this. Otherwise, in terms of limitations, this is a scoping review. So it gives the broad strokes of the state of the literature, but we cannot draw any like precise conclusions. And we did also include all types of study designs. And there were, of course, some studies that were more rigorous and others amongst the ones that we included. So just to conclude, there is a need for more validation studies. We can also use these IMUs in injury prevention. So it can be used to determine injury risk factors and compose assessment tools that can be used to determine which athletes are at risk for injuries and to make injury prevention programs. It can also be used to assess the injury biomechanics to further pinpoint the targets for injury prevention during specific injuries. And it can be used to assess basically fatigue and workload in athletes and to provide guidelines to limit injuries when a certain threshold of fatigue is reached, for instance. And in terms of rehabilitation, it can be used to better structure rehab programs and assess for improvement during the entire rehab process. Yeah, so thank you.
Fantastic, thank you very much. I guess a lot of that will improve with the newer technologies, I would imagine, right? The capturing, markerless capturing.
Mm-hmm. Yeah, it's still like in evolution for sure. So we'll see how it really, there's a lack of standardization. I think that's the main issue. And we really need to work on more standards for evaluation of these technologies.
Certainly, yeah. Oh, great, wonderful. Any questions? Anybody like to make a comment, question? Feel free.
Yeah, so excellent presentation. So which one is more accurate, markerless or marker-based motion capture? And can you do some sort of hybrid? Are there studies that show some sort of hybrid?
Well, so I cannot say for sure which one is better because, like I said, the lack of standardization, the goal right now is the marker base. So that's the one that's considered the most accurate at the moment. So there's really more studies that need to be done to determine which ones are better in which context. And in terms of hybrid, I did read a few things on that, but I'm not really well versed. I can look it up, or maybe Dr. Veilleux knows a bit more about it.
Yeah, there's not a lot of studies using hybrid systems. I've seen a few using IMUs and camera-based markerless systems. And they seem to provide the best outcome compared to either one isolated, because the IMU can complement well some of the weaknesses of the camera system. For example, the rotation of the limb in the transverse plane or the axial plane is not an easy thing to do just based on camera images. So the IMUs can contribute and improve that measurement. But that's the best I know for now. And the gold standard is usually the marker based, because it's been used for almost 40 years now, and the camera are much better than they used to be. It's going to be a little bit in my talk later, but so there's a need to do validation studies, as Erica said, comparing the marker based and the markerless system before we can conclude which one is the best. And some may be useful for a specific need that you have, but not for other. So IMUs may be good for the field, for example, but not necessarily to do rehab monitoring.
Okay, thank you very much. Thank you, Erica.
Thank you, Erica. Good presentation.
Thank you.
So thank you very much, Erica, for that wonderful presentation. I think it's a preamble to Dr. Louis-Nicolas Veilleux's presentation. It's a pleasure to introduce Dr. Veilleux, and thank you for agreeing to come and give your talk. Dr. Veilleux is the coordinator and principal investigator of the Motion Analysis Center at the Shriners Hospital. He's also an associate professor in our department. He's a kinesiologist by training, and he also holds a Ph.D. in human kinetics from the University of Montreal. And his specialization is in human movement control and learning. And he completed his postdoc between 2010 and 2015 at the Shriners Hospital and the Department of Pediatrics at McGill under the supervision of Dr. Frank Rauch. Concurrently, he trained in quantified gait analysis at the Marian Farr Rehabilitation Center's Gait Analysis Lab. So his primary research interests are studying the musculoskeletal system and its relationship to movement in healthy and pathological children. He's also interested in sports medicine and injury prevention in healthy children and adolescents. So in all of his research and clinical work is focused on providing better care to patients and improving their quality of life. So Dr. Veilleux has published more than 40 peer-reviewed scientific articles, which have been cited more than 700 times. So it's a pleasure to welcome you, Dr. Veilleux. It's all yours. Thank you.
Thank you very much for the introduction. Thanks for having me today. Just give me a second. All right, do you see the presenter mode or you see
The presenter mode.
a second. And now?
All good.
All good. All right. So, all right. So today I'm going to present a little bit what is motion capture basically and how it's being used right now in movies and video games and how it contributed a little bit to improve what we are using in the healthcare system. So I'm going to give you a little history about motion capture, and then I'll go through clinical cases to exemplify the work we can do in the clinical motion analysis embedded in a hospital setting. And we will talk a little bit about one research project we are currently running at the Motion Analysis Center. And I'll end this talk by presenting some sports medicine future avenues. All right, so I have nothing to disclose. So probably most of you have seen feature of behind the scenes of movies and video games, how it's being done right now. On the right, you can see Gollum from the Lord of the Rings and how it was created in motion through motion capture. On the left, you can see one of the NHL hockey game edition. And how it's done and why the images look so realistic right now. It's because it's actually true human motion that's applied to a virtual avatar. Here we can see what's the rendering that was done in the 1990s with the NHL game. And on the right, you can see now what it looks like. So it almost looks like it's a real event going on. Because of partly because of the motion capture that's being done for those video games. So, but how did all of this started? We have to go back to the 1800s, and it's Mr. Leland Stanford, who was the governor of California, that was also among other things a horse breeder and the founder of Stanford University. And he was really interested in the horse as a horse breeder, and he was looking at this picture that you see on the screen right now, and he started wondering if it was a real depiction of horses and truly how they moved, because it didn't seem like horses would run with all four legs in such a motion like that with spread out legs in front and behind. And so he went and tasked Edward James Murbridge to find a solution and give him the answer about if the legs of the horses are at some point not touching the ground during the running pattern. And so Mr. Murbridge developed a system of multiple cameras that could collect images in a short period of time. And that's pretty clever how he finally did photograph the horse. So what you see here on the image is all the cameras are aligned here. Are aligned here. And they were attached to a wire here. And when the horse would come across running, it would start all the camera one after the other ones. And that's how he was able to capture the horse running. But at the same time, there's a Frenchman, Etienne Jules-Marie. So note that they were using the same initials for their names. And working on similar stuff. So he invented the image gun and was able to capture fast images of flying birds, for example. And he was very interested in capturing human motion. So there's somewhat a bit of a debate on who invented actually the motion capture. I'm not too involved in that debate because none of them were Quebecers or Canadians. So I will let that to the Americans and the French to dispute who was the first. Here, what we see is the results of Muybridge photo capture. What we realize after all is that indeed the horse is leaving all 4 foot at once from the ground, but the legs are not spread out, but rather tucked in underneath the horse. So he was actually able to capture the motion of that horse and answer Mr. Stafford's question. On the right here, what you can see is the Frenchman's photographs, and you can see he captured human motion. And the advantage of this system was that the image he was taking were all on the same frame, contrary to Muybridge. So a bit more adapted to evaluate human motion. All right, so we went from still images, and in the 1980s, 1990s, we started to use 2D video-based image to start doing the video games. So here on the image, you can see on the left, it's the little brother of the game creator from Prince of Persia. That got filmed, and the creator of the Prince of Persia used these video to implement in the first version of the game. And on the right, what you can see is how they are now using motion capture with marker-based suits to create the virtual avatar for the video game, the Prince of Persia video game. And actually, I used to play that video game on my IBM PS1, and I have to admit that the motion of the little avatar was quite realistic at this time in the 1990s. But now you can see that the image quality is much better, and this is the game from 2021. So all of these video games and sports industry investment into motion capture really help at improving the technology, and especially the camera systems that we are now using, which are much more efficient than they used to be 30 years ago. And so we were able to implement this in a hospital setting. And we have to understand the context. So the Shriners Hospital in Montreal is part of multiple hospital network. So we have 20 Shriners Hospital across North America, 18 of which are orthopedic hospitals. And from these 18, 13 has a motion capture laboratory within the hospital. And because the hospital is specialized in pediatric orthopedic care, most of the children attending the hospital have musculoskeletal disorders that will affect their motor function and locomotion. And therefore, they are good candidates for a gait analysis, because most of the surgeries or treatment that will be done with these patients are aiming basically at restoring as much normal motor function and locomotion as possible. So the main patient population for which the gait analysis was actually developed is the patient with cerebral palsy. That's the pediatric disorder with the highest prevalence, and it affects quite severely their gait pattern. We can see here on the left. So first he needs walker to help him walk. We can see the knees are always flexed as he walks. And we can see from the other video that the knees are crossing, so it's called a scissoring gait. Doesn't put the heel on the ground too. But we see many other different disorders. This young lady here had foot deformity. So it's not as evident as for the patient with cerebral palsy that she has some gait deficit, but we can appreciate that she's doing very small steps, and that's a problem. The foot function is also altered in this patient population. So if you're a surgeon and you see those patients, you can always use observational gait analysis. So you can have your patient walk in the hallway and visually assess their gait in the frontal plane, so from the front, and from the side, so the sagittal plane. This is highly subjective, and it's a good start, but it's not as detailed as a fully quantitative gait analysis. You could go in between using some visual scores, such as the Edinburgh visual gait score that we have here. It's a score that's been validated to use with patients with cerebral palsy. You can, for example, calculate pre-treatment and post-treatment, or with and without orthosis, for example, and the score will tell you some information about the improvement that the treatment or the orthosis can bring with these kids. And you can use some software like Veilleux is a software where you can use the still images of your videos and calculate the angles that you need for your gait analysis, as we can see here. All right, but as I mentioned, the previous approaches are either subjective or semi-objective. But what if we want to objectify everything? So you need quantified motion analysis. And at the Shriners Hospital that was built and finished in 2015. So we started with nothing in the room, basically. So we had a 20 by 40 feet room with no cameras, no electricity, no force plates embedded in the ground. So I had to use a 3D rendering of the room to be able to do my presentations. But then the Vicon engineer came to set us up with the video cameras. As you can see here, we have 10 cameras, and we also started to set up the force plates, but we needed to dig into the ground of the floor in order to be able to implement those force plates. And then that's almost the final product here. But once we have installed the force plates in the ground, we realized that the floor was a bit off, and so we needed to redo the floor before we can finalize everything. And so now this is a current rendering of the motion capture laboratory, or the motion analysis center at the Shriners Hospital. So we have a walkway in a dark fashion so that the force plates are not easily visible for the patients. And we have some nice equipment. So if you want to start a motion lab, you will need equipment, and it's as Erika mentioned in her talk, that can be very costly. So overall, the lab is equipped for around $750,000. Just the camera system are 15,000 each. We have 10 of them. Sorry. We have a clinical bed for the physical therapists to be able to do their physical evaluations. The cameras, we have 4 force plates. So the force plates are there to measure the ground reaction forces. More is the better. So we have 4 for now, but we're aiming for to acquire another one. The reason for that is that kinetics are hard for the patient to hit specifically on one force plate. And so we need a lot of trial to have good force plate contacts. And so if you have more force plates, then the patient needs to do less walking. and some of these patients tires easily, so it's a good thing to have a lot of force plates. And finally, we have the EMGs. Nowadays, we have wireless EMGs, and with the kids, it's pretty awesome to have. So as I mentioned, the investment from the movie industries really help improving the camera systems. And if you look on the right side here, that's the old marker set. So there's not a lot of marker because it would saturate the camera very fast if we added more markers. But the cost of that is less reliable data because the cameras could more easily lose sight of one marker. And nowadays we use a lot more markers, so the data are more reliable and therefore of better quality to assess our patients. Another thing that really changed over time is the EMGs. So here on the left, you can see that's an image from Northern California, Shriners. And so the kids would basically walk with a backpack full of wires that would attach the EMGs to. And one can wonder how much a natural walk it was with this kind of equipment on the back of a little kid. Nowadays, we use, that's the Thesis system here. It's pretty convenient because we only have one electrode that's all in a small device, and you can fix it right on the skin with just a double phase tape. So it's very handy, and for the kids, it's super easy to install. Having all the equipment is very nice, but you also need the staff. Obviously, you will need your medical staff. The medical staff need to have trust into your data and your interpretation. So it can be a long process to have the surgeons on board with your department. So you need to do a lot of education, organize a lot of meetings to discuss the patient cases. And that's how you will eventually get your surgeons to send the patient to the motion analysis center. So they need to be able to understand what you can provide to them before they will send you the patient. You need some administrative staff, which I am part of, as well as research. But the most important part is truly the clinicians and the staff from your lab. The physical therapist will do most of the clinical job, so assessing the patient, preparing the case, doing the data interpretation. The biomedical engineer is there to be the data keeper, if you want. He's going to make sure that the data collected are of high quality. There's a lot of post-acquisition data processing that needs to be done. And he's the one who knows which filter to apply and how to fill the different gaps in order to have the best data. And don't neglect the administrative assistant who's scheduling all of the patients. And for her, having a knowledge of all the patient population is quite an advantage for us at the Motion Analysis Center in Montreal. So without the staff, you won't be able to do clinical activities of high level. So this year we're celebrating the 5th year of opening. I just wanted to plug that in my presentation, and we did a dedication ceremony on March 15, 2017, but maybe some of you will remember that it was the snowstorm of the century. Everybody was stuck on the 13, but we still had some people to come and visit the Motion Lab for the opening, and ladies of the Oriental Shrine of North America are the ones who provided the funds to finance the Motion Analysis Center. And we had the traditional ribbon cutting ceremony. Since the opening, well, we grew quite a bit from 2019 to 2020, going from 200 to almost 400 patients in a year. With the COVID that hit lately, we suffered a little bit from that. We went back to the levels of 20 18. But still, over the last 5 years, that's more than 1,000 patients that benefited from the Motion Analysis Center services. So if you're a patient and you're asked to come to the motion analysis for a gait analysis or a sports medicine analysis, what is it that you have to expect? So as I just mentioned, we have 2 service lines, clinical gait analysis or sports medicine, and we do some research, but we try to embed the research within our clinical activities. So what will you do as a patient for clinical gait analysis? You will have to do some patient-reported outcomes measures. So at the Motion Lab here in Montreal, we use the POTCHI, which is orthopedic-based PRO. And we also use the Functional Activity Questionnaire, which is more of a functional PRO. So how good a patient is at doing everyday life activities. But if you're interested in using those patient-reported outcomes, there's basically one for every need you will have. There's some for the knee, there's some that are general for the function, there's some for the hip, and there are some that are more general, like the PROMIS, which is very popular nowadays. And so we will trade the POTCHI for the PROMIS eventually at the Shriners. The other thing you have to expect is to go through a clinical examination with the physical therapist. So what we can see here is the range of motion at the hip, but we also do the knee and the ankle. If it's a patient with cerebral palsy, we'll look at the tone and the spasticity. And finally, we will do a full muscle strength assessment at the hip, knee, and foot again. If you have a foot deformity, in addition to other musculoskeletal problem, we will go through a foot evaluation too, either in a non-weight bearing position and in a weight bearing position. Once the clinical exam and the PROs are completed, you will go through the marker placement and defining the knee rotation axis. So that's what we can see here. The knee is defined with the knee alignment device. That's a special device that will allow you to better define the knee axis. This has changed now. We're just using markers to define this knee axis. Here, what you can see is a little video of what the output may look like. So once the markers are set and we have done a static data capture, we go and have the patient walk in the motion lab. And what you see here is so all the markers that we've put on the body are linked together to define the pelvis, the hip, and the knee and the ankle, and this is how we can calculate the kinematics, so the dynamic range of motion or during the gait. The other thing we have too is the patient, as he walks, will hit the force plates. As we see here, he hit perfectly the force plate number 1, and the color graph you see here is the ground reaction force over time. And we can see that when we hit the ground first, it's the weight acceptance. So there's a lot of ground reaction forces. As we go through mid-stance, the forces goes down, and then it goes up again when you push off to move forward. Once all of this is done, the engineer will prepare the report, and the physical therapist will grab all of this information to provide its report recommendation for conservative treatment, physical therapy. And then we will eventually meet with the surgeon who asks for the evaluation, and he will decide whether his surgical plan is good to go as he previously planned, or if he needs to change anything based on the gait analysis report. So I just want to show a little bit of how we can improve, or we can be used to for the surgeon to use our services. So here we have a patient with cerebral palsy, with spastic diplegia and dysplasia of the right hip. So she was referred to the Gait lab for pre-operative assessment. It was more to do a baseline analysis and not necessarily to change what the treatment plan was. So on the top part, you can see the patient pre-operatively, and on the bottom part, you can see the patient post-operatively. On the graphs, we look at the left side and the right side, and the pelvis, the hip, the knee, and the ankle. The blue line is representing the preoperative data. The red lines are the postoperative, and the gray band is the norm. So what we can see is that the blue lines, especially at the pelvis and the hip, were outside of the norms, but after the surgery, we were able to bring the kinematics of the pelvis and the hip closer to the norms, as well as the foot on the left side, and that's basically the same on the right side. Perhaps most strikingly is the gait deviations that you see in the frontal plane. You can see here that she drops a lot on one side with the shoulder. That's a Trendelenburg that occurs when some muscle weaknesses of the abductors are seen. And you see also the knee that are crossing over the other. So that's called knee gait scissoring gait, sorry. And post-operatively, you can see that the scissoring gait is almost disappeared. And there's still a little bit of Trendelenburg with the trunk bending on the side, but not as much as it was before. And again, if you look at the blue curves at the pelvis and the hip, they were way out of the gray band, which is the norm, and the red is now much closer or in the norms now. So that's one example that we can see how much improvement occurred following a surgery. So the second use we can do is to decide whether a patient will undergo conservative treatment, or if it will he will undergo surgical treatment, and what kind of treatment he will undergo. So we see a lot of patients with lower extremities torsional abnormalities. That's called LETA. We have a special set of these LETA that's called miserable malalignment syndrome, and it's a combination of excessive femoral introversion, inward-facing patellas, and outward tibial torsions. And those kids have excessive pain at the knee and hip, and eventually, because of the pain, they will stop all physical activity that they were doing. So we had these two patients coming in to the motion analysis recently, and reviewed them together with Dr. Bernstein, who's the surgeon who sends those patients to the motion lab. And it struck me as we presented them that they looked very much alike in terms of deformity. So if we look at the right side of patient 1 and patient 2, they're very similar visually. So the femoral anteversion, inward facing patellas, and external tibial torsion. And if we look at the CT scan results, we can see that the right was 21 degrees of femoral introversion for the patient 1 and 40 degrees of external tibial torsion, and that's 19 and 43 for the patient 2. The left is a bit different with a less severe condition for the patient 2, but let's focus on the right side for the rest. So if you're if you're a surgeon, you're going to have access to the clinical evaluation in addition to your visual examination. And here again, they're pretty similar. What we observe is increased hip internal torsion above 60 degrees, which is more than the norms. And the external rotation that's limited, which is roughly 20 degrees different, lower than what should be expected from the norms. And this is the same for the patient 2 with, again, over 60 degrees of internal rotation and over 30 degrees of tibial external torsion. So probably based on what you have until now, you would have decided for the same surgery or the same treatment plan for both of these young kids. And I think that's where the Gait lab, but also the PROs we're using at the Gait lab applies. Here, what we see is that one patient had very low score at the PODCHI, so sports and physical functions at 42 and pain is at 58. Every 10 points below 100 is a standard deviation below the norm, so that's quite a severe condition here. Whereas the other one, she's pretty happy and have a great global function of 86, and the pain and sports is not completely limited or very low scores. So the impact of the disorder is much less on patient 2 than patient 1. And if we look at the functional activity questionnaire, the patient 1 has a score of 49 out of 88, and the higher the score, the less you can do. So she's quite limited in terms of everyday life activities, whereas the other one, she has 26 out of 88. It's only 4 points above the minimum needed. So she's quite functional still. I will just skip that. Whoa. Sorry about that. Sorry, I don't know what happened. All right, so there was not much going on the sagittal plane, but the deviations occur mostly in the axial and the transverse plane and the coronal plane. So that's what we see here for this young lady. Just looking at the video, we can see that there's something wrong with her gait pattern. We can tell that she's not walking normally, but if we look on the transverse plane, which is the rightmost column here, and the second figure from the top, you look at this hip rotation going from 0 to 45-degree internals as she walks. So that's pretty severe. And that may be where the pain comes from. If we look at the other patient, it's much less severe. The gait pattern is much better, and only the right side shows some abnormalities at the hip. and the dynamic internal rotation is not as severe as the other one. And so based on these gait analysis information and on the PROs, what was decided, it was that the patient one with the low PRO scores, the important gait deviations, along with the bone scans, it was decided that this patient would undergo surgeries, derotational osteotomies, and we would go conservative with the patient too, because she was still quite functional and the pain was not too severe. So we currently have a grant for the next 3 years to assess this patient population. So there's not of things that are not understood with this patient. How much time I have left, Michael?
Okay.
So it's 2:10. Yeah, you have time. You could go.
Yeah.
Mhm.
So, there's a lot of health professionals that are unable to diagnose properly this knee pain, anterior knee pain problem. So that's one thing we want to show with this research project is how it affects the rotation affects the knee or will bring the knee pain. Some things that the surgery is only for cosmetic purpose, but we truly believe based on our experience that those are suffering from deficit in physical function. The origin of the pain is uncertain, and despite correct diagnosis, conservative treatment most often fails. So we need to know the short-term and long-term impact of the surgery, and that's what we want to do with that project. So it's a multicentric prospective study. Pre to post surgery study design. We'll recruit 28 patients. And just want to mention that we embedded this research project in the clinical standards. So it's not much procedure added for the patients and for the staff of the Motion Analysis Center. So it's quite a nice project that we have devised here, I find. And we have some preliminary results because we've been doing this little project unfunded for a year or so. And so we have 8 participants who did the 1-year follow-up after the surgery. This is briefly what was done as a surgery. Here what we see is on the left is the patient on pre-surgery. So you can see the inward facing patellas, the femur are internally rotated. That's quite impressive to see here. And here we can see that the patellas are now facing in front and that the femurs are now more aligned than it used to be. This is the preoperative gait here and the post-operative. So one can appreciate that there's a little less motion at the knee on the right side and on the left. Here, what we see, so in the red is the pre-surgery. The norms are the blue lines, the dotted blue lines, and it represents one standard deviation. And the green line is the post-surgery data. So here we're looking at the hip rotation. So it was way outside of the norms before the surgery, and now it's within the norms. If we look at the knee rotation, we can see that it was out of the norms pre-surgery and now within the norms. And one has to notice that the foot progression and the foot rotation didn't change much because we somewhat realigned both so that the foot would stay mostly straight. But perhaps the most important results of this little project is how it improved the patient-reported outcomes. Here we can see the pain went from an average of 37 up to 70. So that's quite an improvement in terms of patient-reported outcome, and as well as the sports and physical function that went from 50 to 75. So we're starting the new project now that's being funded, and that's the team I would like to thank here in Montreal. So I just want to finish with the sports medicine. I'll go quickly over that. So here what we are testing is the effect of the brace on a patient with osteochondritis dissecans. So that's a bone problem at the knee that suffer many kids, growing kids. And what we see here is that a kid with this kind of problem often have a little varus as they walk, expressed by the red line here. And they have diminished knee external adduction moment if we compare, so the red line compared to the blue, which is the healthy knee, and the control is the orange. So here what we see is the effect of the brace. So the knee is the blue line, the knee brace is the blue line, and the natural gait is the red line. So we can see at the knee valgus varus here that the brace is bringing the kinematics of the knee into the normal range compared to when the brace is not sorry. All right. So that's one thing we do for sports medicine, but we also do return to play. So we have 4 surgical orthopedics surgeons, that send the patient to the motion analysis center. Dr. Poyo is based at the Shriners, so he's the one who's sending the most patients in. But we also work with Dr. Martineau, Berman, and Janelle. Janelle also is at the Shriners, but she's doing more upper limbs than lower limbs. We've published a few research with that group of surgeons. But the main activity at the Motion Lab is the isokinetic knee flexion extensor testing for the return to play. So that's a isokinetic dynamometer. So basically the knee flexion is an extension is done and measured at a constant speed. We will look at 3 different risk factors for re-injury after ACL reconstruction surgery. First is that we look at the limb symmetry index. So we compare the non-affected to the affected limb. And we will do this at 3 different speeds on the isokinetic dynamometer. And we will calculate the % difference between the sides. And here we see that this patient was pretty good at slow speed, which is 60 degrees per second. He only had 11% difference between his quads on the right non-affected and left affected side. As we go to faster speed, he increases difference between sides. And usually it's because of where they are in their rehab process. So if they have started jumps, usually the difference at higher speeds are less. Second thing we look at is the hamstring to quad ratio. So the quadriceps are very strong muscles and they generate more force than the hamstrings, but we expect the hamstrings to be producing between 60 to 80% of the quad strength. And that's what we see for this patient. Below that, it's recommended to train the hamstrings so that they get closer to the quads because they somewhat do the same function as the ligaments. So it kind of protects the ligaments if you have a strong hamstring. And the last thing we will do is that we will compare with patients of same sex and same body mass. And we will calculate the Z-score. And if you're below 1 or 2 Z-scores from the norms, then you need to increase your basic strength because if you're not strong enough, again, that's a risk factor for re-injury. But despite all of these testing on the isokinetic dynamometer, there's over 250,000 ACL injuries in a year in the US, and 20 to 25% of ACL reconstructed patients will either re-tear or tear contralateral side after the surgery has occurred. So despite taking some precautions before returning them to the sports, they still have a great risk of re-injury, and I have to add that many of them will not go back to the same level as they did before. So there's some need to develop new approaches, and that's where we want to go at. And the future directions that needs to be done is to use the motion capture in the laboratory settings first to assess those patients with ACL reconstructed. for the highest quality possible of motion capture, but also move with some markerless systems. So TIA is an AI-based camera system for motion capture. Mo2C and Xsense are IMU-based markerless systems. And those allows maybe for a little less quality, but perhaps easier to bring in, for example, sports school settings. If you want to do a full day of testing, you don't necessarily need to be as precise as someone who's already been injured, but at least identify those that may be at risk of being injured the first time using those systems. They're much easier to bring than a full mocap with markers. And you may have this trade-off between quality and high volume of testing that's possible with this. So that's one of the rendering of the IMU-based system. That's the Xsense that's been in use here. As Erica said, there's some problem with the IMUs. Basically, some of the systems will drift over time. So you have a short period of time to do a great quality acquisition, data acquisition. But the advantage of this is that it's very small, easy to wear, and they can eventually calculate the ground reaction forces, which is not possible on a camera-based system. But the TIA system is very interesting because you don't need any other things than cameras to do the data acquisition. You can monitor as much as 4 athletes at once. So that's very time efficient for someone who wants to test 100 of patients in a few days. And that's not possible with the IMUs. And finally, we will even soon implement at the Motion Lab in the Shriners at Montreal, a motion capture base with markers using return to sport assessment. So patients will perform 6 different sports related motions. So drop jumps, cuts, decelerations, heel touch, and I'm missing a few, but just the idea is to test the movement quality rather than just the performance or the strength assessment we used to do with the isokinetic dynamometer. And so what we do with this information is that we provide a report. So we do the test twice, once at, I'm almost done. So just hang on. What we do is we test at 7 months, and then we test again at 9 months. And so that 7-month testing is to provide this report to the physical therapist so that they know better where are the weaknesses of the patient in terms of motion techniques, as well as muscle weaknesses. So here you see that we have the 6 different tests: heel touch, drop jump, lateral shuffle, deceleration, single leg jump, and side step cut. And here we have different parameters we look at for these different maneuvers, and they will be each quoted as 1, 0, 1, or 2, 2 being the highest score, and a perfect motion. Basically, if you're between 45 and 50, you're at low risk of re-injury. If you're at 35 and 44, you're at moderate risk. And if you're below 35, you just failed the test and you need to continue rehab. So here, for example, what we can see is that this patient had a lot of 1s into his hip stability. So there's probably something going on there. Either it's a bad motion pattern that's being applied, or there is some muscle weaknesses that are too important for the patient to be able to move properly. So the physical therapist can address that with his therapeutic exercises. So that's basically what I had for today. I want to thank all my team that if you see all these great data and video image, that's them who did that for the Motion Lab. So that's very appreciated from them. So from me, sorry. And so that's it.
Thank you very much, Dr. Veilleux. Any questions, please? Just unmute and ask. So did you have floor-mounted load transducers? Because I saw your flow looks quite interesting.
Yeah. So so the force plates are actually, sorry, I'm just gonna stop sharing. Yeah, so the thing is, when the patients walk, if they see the force plates, they will somewhat try to trigger the force plate, and they will not have a normal gait pattern. This will affect their gait pattern. So what we do is we embedded the force plates in the ground. So we basically had to dig a hole into the concrete and put the force plates in there. And so that way it's flush with the ground. And we painted that black and put a black mat around it on the floor so that the patient would not be able to perceive the force plate, so that they wouldn't change, sorry, their normal gait pattern. So that's the reason why the floor is black and why the force plates are embedded in the ground like that.
Okay. Any other questions?
I could, yeah, I have a question actually. So yeah, I could definitely see the translation to physiotherapy is impressive. So you could definitely determine what areas, what muscle groups, where to do the therapy to improve your gaiting and so on, which is quite impressive that you know that the results that you're showing. For the surgeries though, do you have similar, like would you have, or have you had already similar success working with surgeons on how, like, to fine tune, let's say, an operation to improve a specific the gating?
Yeah, so so basically all of the patients are referred to for the gait analysis at least, are referred to the motion lab from a surgeon. So sometimes the analysis will be done to determine, are we going conservative or we're going surgically? And then once it's decided to go surgically, they will use the data to determine, okay, should we, for example, CP patient is quite complex. And sometimes they will think that the hamstrings are too short, and they will try to lengthen the hamstrings. But then they do the motion analysis, and as they walk, we have a measure that's the muscle length that we can derive from the data we're capturing. And then we're realizing that actually the muscle, the hamstrings are not too short. They're actually totally normal. And this impression of them being too short comes from another problem that's not the hamstrings. So in this way, the surgeon will adapt his plan based on the data that we provide. So I would say that probably usually 80–90% of what they decide before the gait lab is kept as is, but sometimes they will decide to remove one surgery or add one or change the type of approach they will use based on those data. But we all gather together. So the physical therapists prepare the data interpretation for the conservative and the physical therapy part. And then we gather with the surgeon who send the patient most of the time to the motion analysis center, and we present the case to him, and he will decide based on that. So we discuss all together the case, and he will base his surgeon plan based on this discussion.
It's quite amazing.
Yeah, but it looks a bit simple, but if your surgeon is not used to interpret those data, it's much harder. So there are courses out there that are being offered to get more because it's not taught in their courses, just minimally. Mm-hmm. So you need to take extra courses to become an expert, or at least attend those meetings where we meet with those surgeons that are experts. We have 3 now that are quite good at interpreting those data here. So Dr. Hamdi, Dr. Quentin, and Dr. Bernstein. Yeah.
Wonderful.
So you look a lot at the pathological gait.
Yes.
So are there specific reflections of compensation? Let's say cerebral palsy, with versus, are there certain patterns? Because I was seeing your data and data and data, and I was thinking, are there specific patterns which reflect compensations?
So that's a pretty good question. First, it's sometimes a bit hard to determine, is it a primary problem or is it a compensation that's occurring? So this becomes easier as you get experience at looking at those patients. But cerebral palsy is somewhat complex because every patient is very different from another one. So there will be some gait patterns that you will see. So there's the crouch gait that we call, for example, where the patient will walk with dorsiflexion, increased dorsiflexion, increased knee flexion, and increased hip flexion. So that's a gait pattern that you will often see in patients with cerebral palsy. Similarly, you will see patients with scissoring gait with the knee going in front of the other knee like that. But other than that, you will see way different gait patterns in those kids. Outside of those very common gait patterns, the rest of it is very different. So you need to look. So for example, the crouch gait is happening on the sagittal plane. It's all in flexion. So you can look at the sagittal plane and determine, okay, is there crouch gait pattern going on? And the knee, scissoring knee gait is in the frontal plane. So you can look at the plane independently and isolate those patterns and then look at everything else. That's probably more compensations than it is a primary problem.
Okay, thank you very much. Any other questions? So if there are no more questions, I would like to thank Dr. Veilleux for that wonderful presentation, and congratulations on your grant.
Thank you.
Look, so this is the last seminar so far. I think we will restart. Mike, do you have some dates for?
Yes, yeah, we will be we'll be beginning in September, on September 13th.
Okay.
Yeah, so that will be so everybody's off. So you guys get a break, and then on September 13th we'll restart our seminar series with some fresh talks.
So thank you very
and we
much.
hope we thank everybody who participated and for your continued participation. Very important to us that you continue.
Yeah. So for the students, Misha will send the results and the awards in the coming weeks. So thank you very much. Thank you much, everyone.
Thank you.
Thank you, Dr.
for
Veilleux.
inviting me.
Bye. Thanks for